All right, so it's 8 o'clock. We're going to probably get started at this point. My name is Adam Singer. I'm a musculoskeletal radiologist out of Atlanta, Georgia at Emory University. This is going to be the first of a series of e-lectures. We are fortunate to have some wonderful speakers in this time of the COVID pandemic to come in and provide some education for trainees and for attending radiologists and clinicians alike. A detailed schedule with revisions will be coming out soon, so look for that on social media. It will update you on exactly who will be recording. Recordings will become available online, and we'll let you know when those are available if you weren't able to make any of these conferences. Not everybody's going to allow recording, so we do want to remind people that some of this material will be under copyright, and attendees are discouraged from personal screen recording, as unauthorized recording, use, and distribution or sale of this material without permission from the speaker is illegal. I'm going to turn this over to my colleague, Dr. Felix Gonzalez, who's going to introduce our first speaker today.
Hi, good morning, everyone. Thank you so much for joining us. I'm Felix Gonzalez, one of the MSK attending at Emory University. Today we have the pleasure to have William Morrison with us, who we affectionately refer to as Bill. Dr. Morrison has many, many accomplishments. Just briefly to introduce his educational life, he went to Rutgers College in New Jersey, then did medical school at Jefferson, and then went away just for a year to Pennsylvania Hospital and came back to Jefferson, where he did his residency and fellowship. Bill Morrison is a powerhouse in MSK. He doesn't need an introduction. Previous SSR president, multiple accomplishments. He has a background in the military and the Air Force. Someone that we admired dearly, that we look up to. He was my mentor during fellowship. His accomplishments go over 200 peer-reviewed papers, multiple book chapters. As a person, he's a friend as well, and we are very proud to have him here today with us. So Phil, if you want to, Bill, if you want to take it from here, I'm going to stop sharing.
Sure, and thank you, Felix, so much, and thank you, Adam and Monica and the whole gang there. You have an incredible section there at Emory, and you should all be proud of what you're accomplishing. Now, can everybody see my slides?
Yes.
Okay.
It's not in presentation mode yet, but we see it.
Okay. And audio is okay?
Yes.
Yes.
Okay. So again, it's truly an honor to be speaking here in this forum, and especially during this crisis. You know, Zoom meetings have become more popular, and it's a great way of education, a great way of having these kind of conferences. I really appreciate you putting this together. And for all of you, this speaker list is amazing. I wish I could unify the whole country here. I can't do that, but I want to talk about unifying some principles in musculoskeletal today. So what I've noticed over the years is that lectures on imaging studies have tended to become compartmentalized. And what I mean by that, we used to have a lecture on MRI of the knee and it would last an hour. Now we have a talk on the ACL for 15 minutes or things. Over time, you know, these things tend to become compartmentalized. The other thing is, historically, findings have been named individually instead of as processes based on the physical and mechanical principles from which they arose. So you'll notice that some diseases have names on them, or they have some nebulous descriptors that define them. And when you see that, and I'm going to get into some of those examples, when you see that, think about what the physiology and the mechanics are of that condition. And sometimes you'll be able to link that process with other processes, some of which have not been yet discovered. And you'll find sometimes that you'll see something and you'll say, hey, that reminds me of something somewhere else. And you'll put those things together based on physiological or mechanical principles, and you'll be able to explain what's going on there. So this lecture will try to outline some of those examples, propose some new ones, but hopefully lead you to a different way of thinking about these things in a unified manner. So the first thing we're going to talk about is a collection of things: impingement, synovial herniations, cysts, and lipomas. Now, how am I going to unify those? Well, you're all familiar with impingement occurring at the shoulder. You know that classic subacromial spurs here narrow the subacromial space and can impinge upon the rotator cuff tendons in between, leading to tendon tears. And we're very familiar with that concept of impingement at the shoulder. Here's a subacromial spur. We notice that there is a tendon tear in the supraspinatus. We also notice that cystic changes often accompany the impingement effect. Now, how about at the wrist? Well, we have ulnar abutment at the wrist. And the principle here is that when your ulna is relatively long compared to the radius, especially when you go into pronation and ulnar deviation, the ulna becomes relatively long. The tissue in between, instead of the rotator cuff of the shoulder, is the TFCC, which then tears. You also get impaction changes at the lunate, which leads to similar findings that we saw at the greater tuberosity in the shoulder: cartilage damage and cystic changes. Now, how about the ankle? Well, we're all familiar with anterior and posterior impingement at the ankle, especially in certain populations. Ballet dancers are a classic population that gets posterior impingement because of the positions that they go into, especially if you have an osteogonum. But even if you don't have an osteogonum, you can get impingement posteriorly at the ankle related to that impaction of the posterior tibia and the calcaneus and the stata process of the talus. And here in a dancer with an osteogonum, you can see what might happen there when you go into plantar flexion. And we call that osteogonum syndrome. But it's really a manifestation of a dynamic change that occurs posteriorly when people go in that position. And that leads to pseudoarthrosis formation and, yes, cystic changes related to the impingement and the arthritis that ensues. We also know about anterior impingement that occurs at the ankle. And this is seen especially in kicking athletes like soccer players. Anteromedially, spur formation leads to impingement on dorsiflexion, and again, cystic changes at the impaction site. Now, how about at the hip? It's been controversial over the years whether femoral-acetabular impingement actually exists. So, does it exist? Well, we know that it causes arthritis and cystic changes. We know that you have a bump at the femoral head-neck junction that creates a non-spherical femoral head. Well, I put one of my technologists in a 3T scanner with their hip completely flexed, their knee to their chest, to see what happens. And here you can see that the labrum is being squished, and the impaction site, even though this person has a spherical femoral head, you see the impaction site here. The other thing you notice is vessels, blood vessels coming in here. That's going to be important later. So, are synovial herniation pits there incidental? Well, a controversy has arose, especially because a famous radiologist, Michael Pitt, has described these pits as being incidental, and they're called Pitt's pits because of him. But that is also where the impaction occurs, with cystic changes that can be related to impingement. So who is correct? Well, the answer is both are correct. There are penetrating vessels at that exact spot of impingement. Why do you have penetrating vessels here? Well, often around the body, at the joints, there are capsular blood vessels that supply the ends of the bones with blood. These happen or penetrate the bone at the capsular junction. So at the hip, these vessels occur in the same spot as the impaction. So you can get perivascular cyst formation around these areas. And the reason is because when the vessels penetrate the bone, it leads to a weakening of the cortex in that location. Fluid and synovium can invade the bone in these locations. We commonly see this at the wrist, especially within the capitate. And you know about these, you see them commonly, you blow them off when you see them on radiographs. But if you look at them closely, you'll see that these are actually synovial herniations occurring at those penetrating vessels, penetrating the cortices. This can also occur at the shoulder. You're familiar with cystic changes from impingement, that occurs anteriorly. But cysts can also occur at the greater tuberosity posteriorly, as you see in this example. Now, these have been described in some settings as related to throwing athletes from internal impingement. So as you rotate the arm around, this area can impact the glenoid. However, this patient who developed cysts over a 2-month period I guarantee you was not throwing at the time, because this is me. This is me when I had a rotator cuff tear. I was not doing anything at the time. This was 2 months waiting for surgery. I scanned myself to see what was happening, and you can see that cyst formation around the vessels. Why is this happening? Because I have a joint effusion now. The joint effusion is putting pressure on the cortex where the vessels are coming in. So at the shoulder, it's relatively straightforward. Anteriorly, where impingement occurs, cystic changes are related to impingement. Posteriorly, they're related to synovial herniations. So here's an example or diagram of how this happens. We have the joint fluid there in blue, the synovium in yellow, vascular supply penetrating at the capsular junction, supplying the capsule with vascularity and supplying the bone, but leaving a hole in the cortex. If you have a joint effusion, that weakened area can cause penetration of fluid into the bone along the blood vessels. Travels along the blood vessels, eventually forming a cyst. And you can see this at the calcaneus as well. Calcaneal cysts are very common at the body of the calcaneus, but if you ever look very closely, you'll find that there's usually a neck going to the subtalar joint at the angle of Jefferson, which is the capsular junction where vessels come in to the calcaneus. So if you look closely, you'll see that these are actually synovial herniations or intraosseous ganglion cysts along those capsular vessel junctions. Even small ones, you'll usually see it looks like a teardrop. And that teardrop is the connection that previously existed to the angle of Jefferson. And some of these grow over time as a one-way valve effect. In fact, if you do an MR arthrogram and contrast gets in the subtalar joint and you have a cyst, you'll see that the contrast often goes into the cyst through that pathway. If you look at the vascular supply of the calcaneus, you'll notice these vessels coming in at the angle of Jefferson, but also at the medial and lateral borders of the calcaneus. That creates a confluence of vessels there at the body of the calcaneus where these cysts emerge. So what happens then? Well, if you know the law of Laplace, which I don't, but I do know that it causes aneurysms because the tension on the wall of a sphere or a cylinder is proportional to the radius of that sphere or cylinder. So as these cysts grow, they put tension on the walls. Now, what's in the walls or what's adjacent to the walls are blood vessels. And this is some speculation, but what can happen then is hemorrhage as the cyst increases in size, with blood extending into the cyst, which can cause pain, sometimes seen in these cysts. Now, how does the bone heal when it gets injured or when something like this happens? Well, bone heals with bone formation and bland bone formation without cortices, without trabeculi, and we call these lipomas oftentimes. So why do lipomas occur in the exact same location that these cysts occur? Well, the original description by Milgram and others was that these are lipomas that some reason like forming there that degenerate into cysts. But I would propose that it's the opposite, that these are intraosseous ganglion cysts or synovial herniations that hemorrhage due to Laplace's law. Healing response leads to fatty marrow deposition that looks like a lipoma. So we're really probably talking about an ectoplasm rather than a neoplasm in this situation. And this occurs all around the body. Again, we're looking at concepts. We're looking at unifying principles. Here's a benign lesion seen in a patient in 1998. The next year, the lesion's going away all by itself. Well, it's not going away, it's involuting. It involutes as a healing response. The healing response deposits fatty marrow that looks like a lipoma. So at this point, would you call it a lipoma? Possibly, but if you had that prior study, you would call it a benign lesion of some sort that involuted. And we see this happening all around the body with cysts that contain fat. Here's an intraosseous ganglion cyst at the PCL insertion in the knee that is forming fatty marrow inside. This is a healing intraosseous ganglion cyst, not a lipoma. There have been some studies done on this. A study from 1978 showed in the histologic analysis of cysts in various parts of the bone show that there's hemosiderin in the walls and newly formed bone representing healing response. So When you see a lipoma, look at the radiographs, look what it originally looked like, and resist the urge to call it a neoplasm. Next, let's talk about fat pads and bursae. Fat pads and bursae have been given some importance and some named etiologies, some named diseases. But keep in mind, fat pads and bursae are often a reaction to adjacent pathology or mechanical disturbances. So would I call this Hoffa's disease? We have edema in Hoffa's fat pad. Well, again, go back to the principle here. When you see the name of a disease and it has someone's name attributed to it, or it has a nebulous description, think about the mechanics and the physiology of what's going on there. So instead of just calling this Hoffa's disease, which the referring clinician's not going to know what you're talking about, look what's happening next to it. This is a patient with Osgood-Schlatter disease, active, bone marrow edema, tendon pathology. So the edema in Hoffa's fat pad is a reaction to what's going on adjacent to it. So here's quote unquote Hoffa's disease. When you see that, think of what's next to it. In this case, the patellar tendon looks normal, but there's synovitis in the joint. So in this case, quote unquote Hoffa's disease is really a reaction to the inflammatory arthropathy. How about edema in the suprapatellar fat? Well, that's been described as a manifestation of Hoffa's disease in his fat pad, which is even more nebulous. Look at what's happening in the quadriceps tendon. There's interstitial tearing here. What's going on in the fat pad is a reflection of what's going on in the tendon. We know that this occurs at the heel. Here is a patient with bursitis, retro-Achilles, retro-calcaneal bursitis, and we know that this occurs in combination with Achilles tendinosis and tears. This also occurs at the biceps insertion at the elbow. There's a bursa there called the basicotoradialis bursa, and we know when we have fluid in that bursa to look at the tendon underneath. And here, a partial tear of the biceps tendon. This also occurs at the gluteus medius and minimus. And unfortunately, sometimes designation as bursitis leads to alteration in treatment options. So when we call something an itis, we have to be aware that the referring clinicians will think that that's inflammation, because the term itis, the suffix itis, means inflammation. So us calling this a bursitis has led to treatment with steroid injections, which actually make the tendon weaker. We know that the bursitis there is usually related to tendon pathology, gluteus medius or minimus tendon tears. And you can see the tendon is completely torn here. So instead of calling this bursitis, you can say there's fluid in the bursa, but concentrate on the primary pathology, which is the tendon pathology, so the patient gets appropriate treatment. Bursitis at the shoulder, the hip has been called the rotator cuff of the hip, the gluteus medius and minimus, the same kind of pathology occurring here. Bursitis associated with rotator cuff tears. You know that bursitis rarely occurs without rotator cuff disease. Now let's talk about bone production. Is bone proliferation or production good or bad? The answer is neither. It's an adaptive response based on stresses and healing response. So let's talk about some examples here. Here at the heel, we have plantar fascia tear. Now, plantar fascia heals with thickening of the fascia, scarring of the fascia. Occasionally, it occurs as ossification. Ossification is an endpoint of the pathway of healing response in the body. We know that when you see ossification of a tendon, the Achilles tendon, quadriceps, we know that that's usually from previous injury and healing response. So how about the meniscal ossicle? When I went through training, I was taught the meniscal ossicle is a normal variation. You know, it's seen in certain people. It's not seen in animals, blah, blah, blah. And I was confused by that because why is that so special, especially posterior horn medial meniscus near the root attachment? And when I was going through training, now we didn't call any root tears. Root tears were not discovered yet, basically. So early when I was on staff, you know, we all kind of discovered at the same time, hey, there's tears of the root attachments here. And then I went back to the meniscal ossicle and say, hey, that occurs at the same location. Same time, Larry White in Toronto was coming up with the same idea, so we published a paper together about the meniscal ossicle. We noticed that this occurs at the site of meniscal tears, very commonly, posterior root attachment medial meniscus. We found a case in particular where the patient had a tear of the meniscus and they formed an ossicle years later. So we have an association there. This is a healing response of a previous meniscal tear. Now, the body tries to heal itself. It can also try to heal cartilage lesions. And here you have, looks like a spike of bone coming off the femoral condyle. But notice next to it, there's a cartilage defect. These are called articular spurs or button osteophytes, and they occur in areas of cartilage damage. It's the body's healing response to cartilage damage. Now, if you have a cartilage defect, the cartilage defect can extend and create a larger cartilage defect, and you can get osteoarthritis. But the body can try to heal itself with stem cells coming from the marrow, forming fibrocartilage or bone formation there. So that's the origin of these articular spurs. Notice also, they're not scraping the articular surface. They're reconstituting the normal cartilage surface here. So they're not evil. They're actually a healing response. And here's another one occurring at the lateral femoral condyle. And you can see that this really reconstitutes the normal articular surface, not scraping against bone. Now let's talk about osteoarthritis and spurs related to osteoarthritis. Are they evil? Are they bad? Are they painful? Well, they're a response to altered mechanics. They're a response to instability. And David Karasik, my mentor, used to say, bone only knows how to do one thing, and that's form more of itself in response to stresses. It's an adaptive phenomenon. Spurs actually increase the surface area, the contact area of the joint, and stabilize the joint. So think of it that way. How about enthesophytes? Enthesophytes are bone formation related to altered mechanics, stress response, or inflammation, usually just altered mechanics. So you have areas of high tension, high stress. It puts stress on the bony surface, which leads to bone formation in response. It's buttressing of that enthesis. When we see plantar fasciitis, again, it's not necessarily an itis, it's not necessarily inflammation, it's mechanical disturbance. It's tears with inappropriate response. When we see bone marrow edema occurring in these locations, that usually precedes the formation of bone. Here with a spur at the plantar fascia origin. We see edema leading to spurs in other locations related to altered mechanics. When you see edema at the medial aspect of the ankle, the medial malleolus, in a non-articular location, right next to the posterior tibialis, ask yourself, why is that happening? A lot of times it's related to posterior tibialis tendon pathology. The altered mechanics of the PTT in the sheath there can lead to bone formation at the retinacular attachment site and a non-articular spur that tells you there's something bad going on with posterior tibialis mechanically. Now let's talk about subchondral stress. I brought up bone marrow edema, and you all know the classic appearance of stress fractures. The bone marrow edema, the low signal line, it looks like an EKG, and that's related to calcium deposition there. Unfortunately, when this occurs in a subchondral location or unusual locations, it's been called by different names. Again, nebulous names or names of people or things like that. But subchondral stress occurs all around the body, related to a combination of instability and load. So we know about subchondral stress fractures now occurring at the knee. We used to call them SONC. We know that they're related to meniscal tears, basically instability, load, altered mechanics. So spontaneous osteonecrosis of the knee, an unfortunate term that was applied. Again, if you look at the literature in the early days of SONC, you'll see that the orthopedic surgeons are literally freaking out because this often occurs after surgery. This often occurs after partial meniscectomy. Again, instability, altered mechanics, and load. The fact that we called it osteonecrosis led the surgeons to think that it was a complication of their surgery. And you'll see in the literature in the 70s and even 80s that they're doing things like core decompressions, they're doing things like tourniquet time, they're changing tourniquet time, they're doing all these things thinking that it's a complication of their surgery, when really it's a consequence of the mechanics. We know this occurs in middle-aged and older patients, osteoporotic patients. We know there's a correlation with meniscal tear surgery, and we also know there's a negative correlation with osteoarthritis. Why is that? Because the bone has buttressed itself already against altered mechanics. Again, osteoarthritis is a protective, adaptive mechanism. So here we have the meniscus. Notice that the femoral condyle and the tibial plateau don't really match up in shape. That's because you need to be able to move that femur on the tibia. The meniscus helps distribute the forces. When you get meniscal dysfunction, extrusion, you get altered mechanics, and that can lead to certain consequences. You have circumferential fibers in the meniscus that stabilize it. When you tear through those fibers or surgically remove them, it leads to extrusion. Now, what happens when the meniscus extrudes? Well, normally, the forces are distributed uniformly. When you get meniscal extrusion, it leads to altered mechanics, concentration of forces at the central point of the articular surface, leading to subchondral stress fractures, or if it happens slowly, to osteoarthritis. So spontaneous osteonecrosis, you know by now, is a misnomer. It's really a subchondral stress fracture that can lead to osteonecrosis if it's left unchecked. In fact, we see this healing. They heal about 50% of the time. Now let's talk about another nebulous description, transient osteoporosis of the hip. It's a purely descriptive name. It was first described in the 3rd trimester of pregnancy, but now we know that it occurs in all kinds of people. But what characterizes 3rd trimester of pregnancy? Altered mechanics at the hip. Now, we notice radiographically, as its name implies, there's asymmetric osteopenia. You'll find that on MRI, there's diffuse bone marrow edema. Now, if you have lucency on X-ray or CT, you know that this is not osteonecrosis. Why is that? Well, physiologically, you need blood flow to and from the bone, to draw calcium out of the bone. Otherwise, the calcium can't leave. That's why AVN is sclerotic. Now, if you have lucency in the femoral head, you know it's not AVN, even if you have bone marrow edema. Secondly, you'll see in these situations, there's usually a line or subchondral crescent that looks exactly like spontaneous osteonecrosis of the knee. So a lot of these, I'm not saying all of them, but a lot of them represent subchondral stress fractures. In fact, if you look at the early days of description of this, you'll find that these were often miscategorized as avascular necrosis, if you look back at the original papers. In fact, if you look at FICAT's classification system and FICAT's original papers and his description of how core decompression helps patients with early AVN, you can read through his paper and find that a lot of those cases that did well with core decompression in the early stages of AVN were actually subchondral stress fractures. It's fascinating to read that early literature. And we know that these often go away if they're treated appropriately. Now let's talk about some other more obscure things. How about clavicular osteolysis? Again, a nebulous description, but what populations get clavicular osteolysis? Weightlifters and following AC separation, instability and overload. Again, this is a combination of things that leads to subchondral stress all around the body. Bone resorption. Again, what happens? How does bone resorb itself? Blood flow, increased blood flow. Now, why is the clavicle so susceptible to this? Well, think about it. I'm going to blow your mind here, but the AC joint is the only connection osseously that your arm has to your body, if you think about it. Now, think about the surface area here, 1 square centimeter surface area. How about you're lifting a bag into the overhead bin? Hopefully someday we'll be doing that again. But that overhead bag, the weight is concentrated across the 1 square centimeter surface area of that AC joint. How about even more load? Weightlifters. What's happening here? All that force is being transmitted through that 1 square centimeter. So that force per area is massive, what can lead to subchondral stress fractures, increased blood flow, and bone resorption. Now talk a little bit about Osteitis Pubis. Again, a nebulous term, even worse because it implies inflammation. At the end point, it's osteoarthritis, basically, of the pubic symphysis. But in the early stages, what kinds of people get this? Childbirth and capsular injury. We call it athletic pubalgia or core injury that Dr. Zoga will be talking about later in this course. Now, load and instability. The pubic symphysis has very thick capsular attachments that are associated with the rectus adductor aponeurosis, and that's the basis of core muscle injury. Disruption of the capsule there leads to instability of the joint with bone marrow edema that looks just like we've been talking about. And what can happen over time is osteoarthritis in one stage or resorption in another stage. What we see on MRI is bone marrow edema diffusely, and we'll often see a subchondral line in the early stages before osteoarthritis ensues. As Dr. Zogel will talk about, this is a consequence of the agonist-antagonist musculature that occurs at the anterior aspect of the pubic bone. These pulling of tensions against each other leads to separation of the aponeurosis and tearing of the capsule of the pubic symphysis. And that leads to altered mechanics and stress response. So in the early stages, again, often you'll see the subchondral line. I'm not saying all cases represent stress fracture, but it's an example of how instability and load can lead to subchondral stress. In later stages, hyperemia leads to resorption. And that resorption can lead to osteoarthritis. And here's an example of a marathon runner that didn't stop running and has tremendous resorption that could be called clavicular osteolysis of the groin if you want to apply an even more nebulous and inaccurate term. Now, I've talked about a lot of situations where we want to make connections. We want to think about physiology and mechanics, but we do have to look at this with data. We have to avoid the tendency to assume that just because things look alike, they're the same condition. That's happened before. Miscategorization of disease and assumptions can lead to alterations in our diagnoses. Example is the osteochondroses. If you look back in the old literature, everything was called an osteochondrosis. If it had sclerosis and collapse of the bone, it was called an osteochondrosis, basically an abnormality of the bone. We know now that this encompasses different disease processes and normal variations of development. So avascular necrosis, some injuries, normal development. So just because something looks like something else doesn't necessarily mean that it's related, but it should make you think, could this be related? One example is Osgood-Schlatter disease. We know that that's altered mechanics in the developing apophysis related to the attachment of the patellar tendon, and the stresses occurring at that weak junction can lead to the findings that we attribute to Osgood-Schlatter disease. But this was one of the osteochondroses described in 1903. Another thing is Kummel's disease. We know that that's a fracture. It's an osteoporotic compression fracture that forms a pseudoarthrosis and a vacuum within the bone of the vertebral body. And that was called Kummel's or Kummel-Cavernier's disease because all these things required multiple people to describe them. But we know now that it's related to osteoporotic fractures. How about Kienbach's disease? Well, described in 1910 when all they had was basic radiographs, but we know now that it's altered mechanics, at least in part related to negative ulnar variance. How about a Kohler's disease, described quite a long time ago, which probably represents normal development, although there's some controversy there. It was actually found in Tutankhamun when they looked at his x-rays. So I hope this talk at least brought up some ideas, some concepts, so that you look at the big picture, especially when you're seeing these compartmentalized lectures. And again, my mentor, David Karasik, used to say, when something looks confusing, try to put it in another bone and see if it makes sense. And that kind of concept will help you throughout your career. So look at the big picture. Is this the screen by Edvard Munch, or is this normal anatomy? Is this Madonna and baby Jesus? Or is that a ganglion cyst at the knee? Is this Michelangelo's David? Or is that an osteochondral lesion of the talar dome? So give yourselves a high five for putting up with my talk. And I really appreciate this and your attention. You can follow me on Twitter at Morrison MSK. If you have any questions about this, please email me, william.morrison@jefferson.edu. And again, thanks for your attention.